So I'm going to present today the big picture board review on hepatobiliary diseases. Once upon a time I did like to do GI, or wanted to do GI, so hepatobiliary was always one of my favorites. So it was a good topic for me. Like Dr. Aller said, the Chief's going to be doing this podcast series for some of the big picture board review book. So just a little bit of an anatomy review. So here you can kind of see a diagram, and here maybe like a netter's wannabe over here on the other side. But we have the gallbladder, which connects to the cystic duct, and then the cystic duct and the common hepatic duct meet over here. The common hepatic duct is made up by the right hepatic and the left hepatic ducts. And from there you can get to some of the smaller intrahepatic bile ducts, lobules, and that all kind of meets up at the common hepatic duct. Common hepatic duct and the cystic duct meet up for the common bile duct, the CBD, and then and that comes down and it meets the pancreatic duct as well. And that empties out into the ampulla of Vater, into the duodenum. So that's just a small review of some of the anatomy and the different areas we're going to be looking at today. All right, so when you get your big picture book, it'll look somewhat like this, but just so that you can read and follow along, we're just going to break it down a little bit more. So let's start with gallstones. So gallstones, there's a few different types, the main being cholesterol stones, which are, you have a predilection for it. If you're a female, Native Americans do as well. Pigmented stones you can get in chronic hemolysis. You can also get it with terminal ileum resection, which you can often see in Crohn's patients. So Crohn's patients actually have double the risk of general population for having gallstones altogether, and in particular these pigmented stones. And then you can also have mixed cholesterol and pigmented stones. So gallstones, in the bottom you can see those two blue balls there. You can see it's trying to block the cystic duct. So if you have symptoms, or if you have no symptoms, then what do you do for it? Really, you just kind of observe. Lots of times people get imaging, CAT scans for whatever reason, ultrasounds, they may see some gallstones in there. You don't really have to do anything about it unless they're being symptomatic. If they're having biliary colic, so biliary colic meaning like an intense, dull discomfort, primarily in the right upper quadrant. You can have it also in the epigastrum. It generally will radiate to the back. Classically, you think about the right shoulder blade. If you have those, that's essentially biliary colic, which we associate with a fatty meal, and then the gallbladder is contracting, pressure builds up in the gallbladder, and then one of these stones will block the cystic duct outlet, and that's when you start having this pain, biliary colic. And that can progress sometimes to acute cholecystitis, which we think of right upper quadrant pain, fevers, you have a Murphy's sign. We'll get a little bit more into that later. And then gallstones can also get lodged into one of the biliary ducts and often the CBD, and that's when you think of choledocholithiasis, and that you can present as acute pancreatitis, you have jaundice, hepatitis, also develop ascending cholangitis. So now going on to choledocholithiasis, which you can see can obstruct the common bile duct. We have it there kind of next to the ampulla of Vater. You can actually initially will see an increase in the AST and the ALT. It's usually transient up to 1,000 for each of them. And then the elevated alk phos and bili will actually come after that. So to evaluate, initially you're going to get an ultrasound. However, this isn't as good for a distal CBD, kind of the one that we have as an example. CT can sometimes pick up on it, but again, isn't as good. But ultrasound is usually the first imaging modality that you'll use. Then you can go into MRCP, and if someone is down in there, then they may also employ EUS to take a look at it. They're definitely more sensitive for seeing these stones, especially in the distal CBD. So there's some question as to what the cutoff should be in terms of how dilated the CBD should be. So 6 millimeters is a typical cutoff. I think here I've often seen 8 millimeters as the radiologist will read, but 6 millimeters is usually the cutoff, because if you have higher 8 millimeters, then you may actually miss some stones. And then there's some, so 0 to 4 millimeters with dilation, it's been shown to have 3.9% of that has stones, 4.1 to 6, 9.4%, 6.1 to 8, 28%. So if your cutoff is only 8, then you're missing already 28% of stones. So that's why it may be actually better to have a lower threshold of 6 millimeters. But then once you get 8.1 to 10, and then 10 and above, 50 and or 32 and 50% respectively. So that's on ultrasound, and that's when you see the CBD dilated. So again, some complications can be pancreatitis, depending on where the stone is lodged. You can also get ascending cholangitis, and then the treatment is ERCP. So you contact your GI people if you see a CBD stone, and get them on board pretty early, especially if it's a Friday. See if they can do it that day. If not, they may have to wait or come in on a Saturday. But yeah, ERCP is the mainstay for stone removal. You can also get other causes of obstruction in the CBD. You can have stricture, you can have a mass, you can have an organism like a bacterial infection causing cholangitis. Specifically for gallstone pancreatitis, so when you have an elevated lipase, amylase, with also an increase in AST, ALT, and then you see some gallstones, or if you see some ductal dilation, what you're definitely going to have to do is an ERCP for the stone removal. And actually, it's recommended that they get a cholecystectomy to prevent this again in the future, once your pancreatitis has resolved. Even within the same hospitalization, within 7 days, it's shown to be pretty safe for getting the cholecystectomy once the pancreatitis has kind of started to improve. All right, so next we'll move on to acute cholecystitis. So calculus cholecystitis, meaning cholecystitis, so inflammation of the gallbladder itself being caused by a gallstone. So we know that this is going to be fever, leukocytosis. You get a lot of prolonged right upper quadrant pain, and then the Murphy's sign, which when you're taking a deep inhalation, you stop breathing. If you palpate in that area because you've started touching the gallbladder, really painful, and you stop breathing. And you can do that, with a physical exam, and then often the sonographer will also do it with the ultrasound as well. Best way to test for acute cholecystitis is going to be an ultrasound again. You see a thickened gallbladder wall. This is the double wall that you see. Here you can see an inner wall and then the thick wall on the outside, which is some edema, and that's kind of the double wall sign that you get. And then you'll see some paracholecystic fluid, some free fluid around there, which you can also see in this picture. You can also see the stones there, kind of lodged inferiorly of that picture. And then you can see the absence of echoes. You see some shadowing, which basically means that the sound waves are not passing through and they're just reflecting back off the gallstones themselves. That's why you get that shadowing there. The treatment is going to be IV antibiotics to start. And then you can do a laparoscopic cholecystectomy within that same admission to prevent this from happening again in the future. So one thing that I forgot to put in these slides is kind of what is the role of HIDA or HIDA scans in this. So let's say you get the ultrasound and it kind of looks like it could be cholecystitis, and then their symptoms are great, or not great, you're not sure. That's the time you can get a HIDA scan. So you use it if your diagnosis is uncertain after the ultrasound. And so essentially what you're going to do is you're going to inject the tracer. It's going to follow up the bile ducts, and if it empties into the gallbladder, then you can essentially say that there is no cholecystitis there, assuming it's not a picture of an acalculous cholecystitis patient. But if it empties into the gallbladder, then that, we have 90% of cholecystitis being caused by blocking the cystic duct by a gallstone. If there's no tracer emptying into the gallbladder, then you can make help make that diagnosis of cholecystitis. That's if it doesn't. If it does, then there's a small chance that stone became dislodged, but you can also start looking at other diagnoses. So that's kind of the use of HIDA scan. But really that's the only time, that HIDA scans are something that we should be using is if there's a questionable diagnosis of cholecystitis. Acalculous cholecystitis, so you get these, classically a very sick patient in the ICU who's been there for some time. The mechanism is that you can have some transient gallbladder ischemia, or there's bacterial seeding of the gallbladder. So the ultrasound will be abnormal, but you won't see any stones. That's when you can use the HIDA, where you don't see the gallbladder even there as well. And then for that, you do IV antibiotics. You don't do a cholecystectomy because these patients are often pretty sick. And a percutaneous cholecystostomy tube is sufficient for treating that in addition to IV antibiotics. So similar, and sometimes you can get these terms mixed up, but it's definitely its own pathology is acute ascending cholangitis, which is our classic Charcot's triad of fever, abdominal pain, jaundice. If you add on hypotension and altered mental status or confusion, that's Raynaud's pentad. The workup for that, when a patient comes in with that, is, again, ultrasound. That's a constant theme here. Ultrasound seems to be the best initial test for sure. And then you also want to make sure you get blood cultures to make sure that they're not developing sepsis or a bloodstream infection on top of that. So you're going to do IV antibiotics. Make sure you cover for enteric gram-negatives and anaerobes as well. And then you need to do urgent decompression with an ERCP, which is actually preferred to percutaneous cholangiography with a biliary tube drain or with a biliary tube place. But you can actually use either, but ERCP is generally preferred. But for whatever reason, sometimes if your center doesn't have it or have ERCP capabilities, then you may have to do the IR intervention instead. So once the cholangitis has resolved, you may want to go for a cholecystectomy to, again, prevent this from happening again in the future. All right, so sclerosing cholangitis. So we have two types here, PSC, primary sclerosing cholangitis, and then we have the IgG4 sclerosing disease, which is often associated with the autoimmune pancreatitis. So starting with PSC, the main risk for PSC is going to be IBD. So 80% of patients that have PSC have ulcerative colitis. And if you diagnose someone with PSC, you better do a colonoscopy to check and see if they have ulcerative colitis. However, only 4% of ulcerative colitis patients actually have PSC. The disease that those ulcerative colitis patients has are usually right-sided, it'll be rectal sparing, so a little bit more abnormal than what you would see with most UC patients. So the symptoms that they'll have is jaundice, they'll have really bad itching, they can develop cholangitis relatively easily, their liver test will be more consistent with like a cholestatic picture. So what you'll see specifically is that you'll see an elevated alk phos, GGT. However, the AST and ALT is rarely above 300. So if you're seeing really high AST, ALT, then you may want to consider different diagnoses. So one of the mainstays of this is actually severe, almost intractable itching in these patients. But the pruritus itself is not necessarily associated with an elevated bilirubin in these patients. So to work them up, you're going to do an MRCP, and then for that, you can see in this picture, you're going to see a lot of intrahepatic and extrahepatic. It's going to look like beads on a string. There's stricturing, which you can see here, and there's also going to be some upstream ductal dilation, especially in the hepatic ducts. So like I said, you want to work up for IBD, you want to do a colonoscopy at the time of diagnosis, and then if they do have IBD, you want to be doing it yearly. So like I said, MRCP, and then you're going to check some antibodies. Now antibodies in PSC, there's, so patients who do have antibodies so PSC patients can have positive antibodies. It can be ANA, it can be anti-smooth muscle or ANCA, but even though they have positive antibodies, there's no one specific that's indicative of PSC. So in addition to those, you can have anticardiolipin, actually, anti-thyroid peroxidase, and rheumatoid factor. They could be present, but it's of uncertain clinical significance. So there's one study that really looked at these patients. 97% of PSC patients were positive for one antibody, but we just mentioned 5 or 6, so there's not one that you can actually focus on. And actually 59% had 3 or more positive antibodies. The only one that they found that was somewhat predictive of the severity of disease was anticardiolipin, and so it actually, if that was positive, then that did correlate with a greater risk score, the Mayo risk score for PSC. So, check the antibody, you do MRCP, you check the antibodies. Liver biopsy, you really only have very specific reasons for doing that. It's going to be if you think that they have small ductal disease, and also if you want to exclude an overlap syndrome, such as with autoimmune hepatitis. Just check an IgG4 level to make sure they're not having IgG4 sclerosing disease, and as always, check an HIV screening as well. So how do you treat? So the mainstay is going to be, and the only way to really treat this is going to be liver transplant. That's when the MELD is greater than 14. And actually, some of the guidelines say that an indication for liver transplant is actually intractable pruritus. You can do ERCP for symptomatic relief because they'll often have ductal dilations and the symptoms of cholangitis. And then so that'll help out with some of these symptoms that they have. But when you do that, you want to make sure you do some brushings and biopsy to make sure that they don't have like a mass or anything in there as well that's associated with it. Now the pruritus, that can be managed with ERCP if they have a dominant stricture. You use antihistamines, you can use some bile acid sequestrants. However, you do not use ursodiol. So ursodiol is more, and it is actually first line in PBC. However, you don't use it in PSC. And that's because, one, it hasn't really been shown to help the itching. It hasn't really been shown to improve survival, and it hasn't actually delayed the time to liver transplant. There's some studies going on, but generally ursodiol is not recommended for these patients at all. So PSC, no ursodiol. PBC, yes ursodiol. And then I don't have any good mnemonics for it, but I'm sure someone can recommend them if they do. Anyone have any? No? PSC, PBC? No. I think there's just 2 that you have to just keep in mind and remember. And so next we have, as part of the sclerosing diseases, we have IgG4 sclerosing disease. So it's going to be associated with autoimmune pancreatitis. If you ever get a GI consult for pancreatitis, any of them is going to pimp you on, oh, well, if it's autoimmune pancreatitis, what do you check for? And you tell them IgGs, and then they'll say, well, why not IgG4? And you say, well, it's because we can't test for that here. So, but yeah, you just check immunoglobulins, and then the IgG4 specifically, if you can check it as a send out, but it may take a while to come back, will be 4 times the upper limit of normal. When you do a biopsy of these patients, it's going to look like lymphoplasmacytic infiltrate. And the patients who do have this IgG4, the pancreas will look like a sausage-shaped pancreas. They may have like a pancreatic mass, and they'll have some pancreatic strictures in there as well. It is responsive to steroids and DMARDs such as azathioprine. Moving on now, let's take a look at the gallbladder. We're going to look at gallbladder polyps and gallbladder cancers. So gallbladder polyps, you can often get incidentally on imaging. When you do get them, if it's above 1 centimeter, or if it's in the setting of PSC, or if it's associated with gallstones, you take it out. So greater than 1 centimeters, you remove the gallbladder, or if you have any size gallbladder polyp with PSC or gallstones, you remove the gallbladder as well. Not the polyp, because that doesn't make sense. Gallbladder cancer, which you can see as our black blob over here. Patients who have this chronic stones or polyps are at higher risk of developing gallbladder cancer. Also, patients who have a porcelain gallbladder, like you can see in this x-ray on the right, they have chronic cholestasis. They can develop porcelain gallbladder. And PSC, all these patients are at higher risk of gallbladder cancer. So when you think you have someone with gallbladder cancer, you're going to stage with an MRI or a CT. So gallbladder cancers are actually pretty late presenting. When you do see those patients, they'll often have right upper quadrant pain, nausea, vomiting, and they can have, if they have jaundice, then that means it's probably a pretty advanced disease. If they have biliary colic, it may be an earlier presentation. Early gallbladder cancer is actually found incidentally when someone does a cholecystectomy. You know, they send it for pathology, and that's when they just check it, and that's when they can see it. So that's why poor prognosis generally occurs with gallbladder cancers, because by the time they're actually presenting with these right upper quadrant, nausea, vomiting, it's usually a pretty late stage disease. So treatment, if it's resectable, you can do surgery with some adjuvant, plus or minus adjuvant chemotherapy or radiation. If it's unresectable, then you may have to do chemo with radiation, but often start looking at palliative options there as well. For prevention of gallbladder cancer, again, you want to be aggressive and follow the guidelines for cholecystectomy. So if they have a porcelain gallbladder, if they have a very large stone, it's greater than 3 centimeters. If a polyp is greater than 1 centimeter, or as we talked about before, any polyps in the setting of PSC or gallstones, you want to take out the gallbladder itself to reduce the risk for gallbladder cancer. All right, so next, cholangiocarcinoma, which is our 3 black lesions that you can see in the CBD at the bifurcation of the right and left hepatic, or I guess the confluence of the left and right hepatic ducts, and then again in the left hepatic duct. So what are the risks for it? PSC, again, is one of them. Clonorchis, which is the Chinese fish, liver fluke. Yeah, Chinese liver fluke. See, I told you Kevin could do this. You can do it with a colodocal cyst, or if you have exposure to thorium contrast. So the locations, you're going to see intrahepatic, it's going to be about 10%. You can have it perihilar, so that's, again, at the confluence of the left and right hepatic ducts. That's actually going to be the most common. That's called a Klatskin lesion. Or you can have a distal lesion, you know, in the CBD or further down in the common hepatic duct. So for these, when it's possible, you want to resect it. The more distal it is, let me make sure. Yeah. So actually, let's talk about when they present. So if it's perihilar, again, that's the most common. If it's perihilar or distal, they're gonna have some jaundice, and then on imaging, you'll see a mass with dilated ducts further up. If they're intrahepatic, such as the one in the left hepatic duct that we have here, when you have those, the problem is they're mostly going to be late stage when you actually make the diagnosis. So distal lesions are, you know, the most commonly to present, and they're also the most easily, or sorry, not the most common. The most common is going to be your Klatskins, but the distals will be the most easy to resect. So, and then you can do a transplant, and this is going to be important. So if it's perihilar, and it's less than 3 centimeters, and there's been no extrahepatic spread, that's when you can transplant them. You don't want to do a biopsy if you think they're going to be a liver transplant candidate, because it's an exclusionary criteria because of the risk of seeding that throughout the liver. So if you think that they have cholangiocarcinoma, make sure you don't biopsy it. You can do ERCP with brushings and biopsy, but don't do a percutaneous biopsy. That's what that should have said. And then if they're unresectable, you want to do chemotherapy. So screening for these, because patients who have PSC are at higher risk, you can do a CA-19-9 yearly and an ultrasound, or you can do an MRI every 6 to 12 months. And that's it.